Good evening. My name is Christina Colón-Semenza, and I'm a physical therapist and assistant professor at the University of Connecticut. I will be presenting lessons learned from the implementation of telerehabilitation for individuals with Parkinson's disease during the COVID-19 pandemic. I am presenting the study on behalf of our team that includes Dr. Jenna Zajac, Dr. Ariel Schwartz, and Dr. Terry Ellis. I will be zooming in on each section of our poster, and I will begin here with our background. Not unlike the rest of the world, our Center for Neurorehabilitation at BU had to suspend services on March 13th of 2020 due to the COVID-19 pandemic. However, our clinic was able to re-engage with our patients 10 days later by March 23rd via telerehabilitation. Our clinic had not previously been providing services virtually, and the previously existent literature to this point in this patient population was heavily based upon care by neurologists. Therefore, we sought to determine whether adults with PD would participate in PT via telerehabilitation. We also wanted to describe the characteristics of individuals with PD who would participate and those who didn't. And finally, we wanted to determine patient and therapist satisfaction with telerehabilitation. Our services were offered to those individuals who were previously scheduled to be treated in person, as well as individuals that were referred by area neurologists and movement disorder specialists. Patients engaged in a standard course of treatment via telerehabilitation, and this ranged in frequency from 1 to 13 visits with a mean of 4 visits, and included therapeutic exercise, neuromuscular reeducation, therapeutic activities, and patient education. Those that did participate were sent a patient satisfaction survey through REDCAT. Physical therapists were individually interviewed through virtual meeting platform by research assistants, and our quantitative data was analyzed using descriptive statistics, while our qualitative data was assessed by 3 coders using thematic analysis. 77 individuals were offered telehealth services, and 55 participants accepted. 22 did not. This resulted in a 71.4% participation rate in telerehabilitation. Participants were mostly white, non-Hispanic, older adult males, and non-participants had similar demographics. There was an 80% response rate for our patient satisfaction survey. 44 of 55 individuals responded. All patients that completed the survey reported satisfaction with their treatment experience. When asked if they would recommend the use of telehealth for physical therapy to friends and family, 82% of participants indicated in the affirmative. When asked if they would want to continue with the use of telehealth, greater than half said yes, they would want to if it was combined with in-person visits. There were several themes that emerged from the qualitative data from the physical therapist interviews. Here I will focus on 3 of the most salient themes: increased access to PT, limitations in assessment, as well as an endorsement of a hybrid model. Here we have provided quotes that exemplify each theme. Regarding increased access, it is what you would traditionally anticipate that we were able to serve participants who were further away from our clinic geographically, up to 100 miles away from the center. We also engaged with 15 new participants who had previously never been patients in our center. However, there was also increased access by physical therapists into the home environment, so that physical therapists were now able to engage with individuals by prescribing home exercise programs that were specific to that home environment. It also allowed for specificity of training with task training, training patients with transfers on that specific chair, couch, or bed. And finally, it allowed for treatment during off times, which was previously challenging to have a patient come into the clinic during an off time. In terms of assessments, physical therapists were able to use easily transferable outcome assessments like the 5-time sit-to-stand, the UPDRS Part 3 components, as well as self-report measures like the ABC and the PDQ-39. However, assessments like the 6-minute walk test and the mini best test were not able to be implemented. So that might be expected. However, unexpectedly, therapists reported difficulty with not being able to see the non-objective measures of movement that they normally see when a patient just enters in and out of a clinic from the waiting room. Finally, therapists endorsed a hybrid model of care. Therapists hope that future models would employ both in-person and virtual delivery of services to compensate for the shortcomings of either type of delivery in isolation. So in conclusion, patients reported satisfaction with increased access to PT, physical therapists reported limitations, but some also positives of this delivery method. So finally, a hybrid model may support optimal delivery of PT services as recommended by patients and physical therapists, and future research should investigate the effectiveness of this model of delivery of PT for individuals with Parkinson's disease. Thank you for listening.